Welcome. I'm Louis Chang, Assistant Professor of Neurological Surgery at Weill Cornell Medicine, and in this presentation, I will be supplementing the chapter on posterior thoracic and lumbar instrumentation with an overview of 3 different techniques for placement of thoracic and lumbar pedicle screws. These 3 techniques are traditional open, so-called freehand approach, the 2D fluoroscopic assisted method, and the 3D navigation method. The latter 2 techniques can be used in open surgery, but in this presentation, they will be described in the context of minimally invasive spine surgery. Keep in mind that slight variations exist for each of these techniques, and this presentation will describe a typical, reproducible approach for each method. Then we will go over some of their advantages and disadvantages relative to each other. Freehand methods for placement of pedicle screws, also considered the traditional method, necessitates adequate exposure of the spine to identify and utilize anatomic landmarks for screw placement, such as in this intraoperative picture of the thoracic spine. For the thoracic spine pedicle screw placement, I will go over the technique as described by Ali Baj. The thoracic spine is exposed, and the superior articulating processes and transverse processes should be visualized. The entry point pilot hole is made with a high-speed drill approximately 3 mm caudal to the junction of the lateral margin of the superior articulating process and transverse process at all thoracic levels. A gear shift is then used to cannulate the pedicle to the desired length as pre-measured on preoperative CT. The medial trajectory is approximately 30 degrees from sagittal for T1 and T2 and approximately 20 degrees for T3 to T12. The gear shift is held in an orthogonal trajectory relative to the sagittal curvature of the dorsal spine. A ball tip probe is then used to check the integrity of the cannulated bone. A tap is then generally used for the pedicle tract prior to the placement of the pedicle screw. AP and lateral x-rays can then be used to confirm placement of the screws. Similarly, for the lumbar spine, adequate exposure must be accomplished in order to properly identify landmarks for freehand placement of the pedicle screws. The creation of the pedicle tract and placement of the screws are oftentimes supplemented with fluoroscopy. The following freehand technique for placing lumbar and S1 pedicle screws is as described by Tim Witham and illustrations are by Ian Sook. For the lumbar levels, the entry point is close to the accessory process as seen in this figure. This is at the junction of the pars interarticularis with the transverse process and the mammillary process of the superior articulating process. The pedicle is then cannulated typically with a gear shift pedicle finder. The medial lateral trajectory is selected based on the surgeon's experience and preoperative and intraoperative imaging, but in general the medial angulation of the L1 pedicle is approximately 5 degrees and increases about 5 degrees for each level down to L5, with the medial angulation of L5 and S1 roughly 25 to 30 degrees. The rostral caudal trajectory can be guided by lateral fluoroscopy. However, this is when the experience of the surgeon and tactile feedback of the pedicle finder through the cancellous portion of the pedicle play an important role in creating the proper angulation and trajectory. After cannulation, a ball tip pedicle feeler can be used to determine if there are any breaches and retarget as necessary. Then the pedicle tract can be tapped with an undersized tap followed by placement of the pedicle screw. For the S1 screw, the pilot hole is made in the inferior part of the superior articulating process of S1 and rectangular area superior to the dorsal foramen of S1. The remainder of the steps are similar to the ones described for the lumbar levels. The pedicle screws can then be test stimulated, and absence of stimulation below 7 milliamps is generally an accepted threshold to indicate unlikely medial breach. The final placement of the pedicle screws can then be verified by AP and lateral fluoroscopy or an intraoperative 3D image acquisition. I will now describe percutaneous pedicle screw placement with 2D fluoroscopy. This technique relies on intraoperative fluoroscopy as well as tactile feedback of the targeting instrument to properly locate anatomic landmarks, since there is no exposure of the spine for visualization. This is my current preferred method, so I will describe my workflow. I prefer biplanar C-arm setup, but one can also use one C-arm and alternate between AP and lateral configurations. First, it is useful to adjust the AP and lateral images for proper projections. For the AP image, the C-arm or the patient bed should be adjusted so there is a linear view of the target level's superior end plate. In this case, the AP is set up for L5. Also, the spinous process is set in the middle of the vertebral body and appears on edge with the pedicle symmetrically situated on either side with the borders distinguishable. The lateral fluoroscopy unit should also be set to a true lateral projection with the pedicles of the target level superimposed. This can be achieved with the use of wig-wag of the C-arm or by swiveling the base. It's also helpful to make some markings on the skin surface with AP view. Using AP fluoroscopy, a horizontal line is drawn across the pedicles and vertical lines marking out the midline along the spinous processes and the lateral borders of the pedicles. Depending on the habitus of the patient, it's generally helpful to mark out the skin entry point slightly lateral to the lateral borders of the pedicles. Typically, this is about 1 centimeter and allows for medialization of the screw. A small incision is then made through the skin and the fascia. A targeting needle is introduced through the incision, and one should aim the tip towards the lateral border of the pedicle on AP view. This should land the tip near the anatomic landmarks described in the freehand section. Tactile feedback and palpation of the tip of the targeting needle on the bony structures can oftentimes aid in the proper localization of the entry point. It may be helpful to use a bevel tip if a diamond tip targeting needle keeps skiving off when trying to engage the bone. The tip of the needle should be sequentially advanced through the pedicle with mallet taps under lateral fluoroscopy. While advancing through the pedicle, it is useful to occasionally check on AP that the tip is going from lateral to medial within the pedicle, but is not projected to extend past the medial wall of the pedicle before it's advanced past the pedicle vertebral body junction. Once the tip of the needle is at or just past the pedicle vertebral body junction on lateral view, an AP shot should be taken to verify the tip is not medial to the medial border of the pedicle. The targeting needle should be advanced further under lateral fluoroscopy, and I usually go to the middle of the vertebral body before the inner stylet is removed and a blunt K-wire is placed through the needle and slightly past the opening of the needle. The needle is then removed while maintaining control of the K-wire the entire time. Once the needle is removed, the K-wire can then be clamped onto the drape, and then the next pedicle can be targeted. When the percutaneous pedicle screw is ready to be placed, it can be helpful to serial dilate over the K-wire, with the outermost tube being the screw insulator tube, which would accommodate passage of instruments such as the tap and ultimately the screw. Use of this insulator tube can be advantageous for a couple reasons. One, it could help to dissect past the fascia and muscle, making it easier for a screw placement. Second, the assistant can hold it steady, giving the surgeon some extra stability in maintaining proper trajectory during screw placement. Depending on the system used, the pedicle may need to be tapped prior to insertion of the cannulated pedicle screw. Meticulous control of the K-wire during this stage is crucial to avoid inadvertent K-wire pullout, advancement into the abdomen, or kinking and sometimes fracturing of the K-wire tip. Once the tip of the screw is approximately at the posterior 1/3 of the vertebral body, I will generally remove the K-wire at this point because leaving it in any further increases the risk of kinking the distal tip of the wire, and removing it sooner may increase the risk of screw breach out of the pedicle. The screw is then advanced to the desired depth. After all the screws are placed, the screws can then be stimulated and AP and lateral shots can be obtained to verify appropriate screw placement. Then the appropriate length rod will need to be fed through the slotted screw towers or tabs, making sure that the rod is fed well below the fascia. The set screws are then tightened down and the towers or tabs are removed. Final AP and lateral shots are taken for confirmation. Percutaneous pedicle screw placement can also be facilitated using 3D navigation. The following technique and workflow are described by Roger Hartle. In this case, K-wireless pedicle screws are used, which eliminates a few steps and potentially avoids K-wire related issues. Here is an illustration of his typical OR setup, with the intraoperative CT positioned at the head and the navigation workstation at the feet. The infrared camera is also positioned at the feet. Here's an intraoperative picture of this setup. Once the patient has been positioned, it is recommended that the skin is taped down to minimize anatomic displacement, especially in obese patients. The tops of the crests are marked out, and 2 dots are also marked out where the 2-pin fixator will be secured into the ilium after palpation of bony landmarks. The patient is then prepped and draped, and a 2-pin fixator using 3mm Schantz pins is secured to the ilium as marked. A reference array is then connected to the fixator. If the surgery is performed in an open fashion, the reference array can alternatively be clamped onto an exposed spine process, typically 1 to 2 levels cranially or caudally to the index level. 2 half sheets are then used to drape on each side of the surgical site, and the image acquisition is performed while the personnel wait outside the OR to eliminate radiation exposure to them. Once the images are processed and the 3-dimensional views on the workstation appear satisfactory, the location of the incision and trajectory are planned with a pointer on the patient. After the surgeon is satisfied with the projected entry point into the pedicle and trajectory through the pedicle, the incision is marked out where the pointer contacts the skin. Once the skin incision is made, it is again advisable to incise the fascia as well, to allow for more facile passage of the instruments and screw to the intended bony target. The reliability of the images should then be verified by insertion of the pointer through the incision and palpation for the transverse process and correlating this to the images on the workstation. After which, the next steps are dependent upon the implant system used. Some systems use a drill guide tube inserted through the incision past the fascial muscle and docking it onto the bone, followed by drilling, tapping, and finally screw placement. Alternatively, one could also use a more streamlined system such as this cannulated pedicle screw with an all-tipped stylet that eliminates those multiple steps. Regardless of the system used, the common thread is that these instruments all have reference arrays so that the surgeon can track the location, trajectory, and depth of the instruments and implants during placement. Again, the entry point and trajectory for the pedicle screw are first planned with navigation pointer. Here is a screenshot from the workstation showing the planning. The screw is then inserted through the incision and under navigation docked onto the desired entry point, and a mallet is used to tap the awl tip to engage the bone. The screw is then advanced through the pedicle under navigation. Once the tip of the screw is beyond the pedicle, the tip of the stylet can then be retracted for the remainder of the screw advancement. Once the screw has been advanced to the desired depth, the stylet can then be completely disengaged and removed from the screw. The screws can be stimulated and another image acquisition can be performed to check the placement of the screws. Finally, the rod can be fed through the screw towers or tabs deep to the fascia as described in the previous percutaneous method. Here's a table looking at a few of the salient advantages and disadvantages of each of the 3 techniques relative to each other. The freehand technique is the traditional method and can be applied to virtually any case that requires posterior pedicle screw fixation, but it has to be done in an open fashion. Since the technology has been around the longest, the implant cost is generally priced lower relative to the newer MIS implants. Additionally, it can be performed just using a C-arm fluoroscopy unit that's less costly than a navigation unit. However, there's much data in the literature to support a higher accuracy rate with 3D navigation compared to a freehand approach, as you can see in this chart. Additionally, Hartle and Shin reported a 15% pedicle perforation risk in non-navigated screw placement versus only a 6% pedicle perforation risk with navigated screw placement in a meta-analysis. For surgeons who perform minimally invasive spine surgery, by virtue of the limited exposure of those types of surgeries, they will need to use one of the 2 image guidance techniques. The 2D fluoroscopic technique is the less costly of the 2 methods, but it generally exposes the surgeon and staff to more radiation than 3D navigation, since the latter group can leave the room during image acquisition. And in both techniques, the learning curve can be obstacles for surgeons only familiar with traditional freehand approach to adapt to newer techniques and technologies. We've covered 3 different ways of placing thoracic and lumbar pedicle screws. In a sense, they're reflective of the timeline in the evolution of methods and technologies for thoracic and lumbar instrumentations. except that the appearance of one technique and its corresponding innovation has not made its predecessor extinct, but rather they currently coexist, with each having its own advantages, disadvantages, and applications. In a way, the different techniques can address different needs. Ultimately, the method that the surgeon chooses will depend on several factors. These may include their training, experience, concern for radiation exposure, access to technologies and equipment, as well as the type of case. Regardless of which method is used, there are fundamental key points and steps, as well as surgical pearls with each method that, if followed diligently and consistently, will lead to highly accurate screw placement, and with it, improve safety and better outcomes for your patients. Thank you for your attention.